there, this is Colleen Hargraves, one of your nursing instructors, and welcome to Module 3. Focus is collaboration, patient education, healthcare recipient. Okay, how do we filter through these concepts? That's going to be our challenge. So let's get going. These slides, I just want to remind you, are here for refreshing, and I included the patient education and family dynamic chapter so that you had something to reference as you're preparing, to incorporate all of this teaching in the clinical realm. So, these topics are refreshers the first few weeks because we're getting ready for clinical, and there's going to be opportunities. Nursing students are so effective at filling these gaps, and hopefully at the end of this talk, you'll see that we have lots of challenges going on in the healthcare field. As a matter of fact, collaboration is so important that QSEN, which is the Quality and Safety Education in Nursing, a task force to really help us achieve better outcomes for our patients, our clients. So teamwork and collaboration is the delivery of client care in partnership with multidisciplinary members of the healthcare team to achieve continuity of care and positive client outcomes. So again, we're thinking of the end in mind. And when we look at this, it's really, at the heart of what we do. The nursing process is all about how do we incorporate a plan that is going to really address every area that we need to. And while someone's in the hospital, there's many opportunities, even though it doesn't end there. We have to bridge that many times to outpatient. So the client is at the center. Client-centered care is really what it's all about. However, we have to get the process started. So know that it is a challenge, especially in acute care. We have short periods of time to get it started, but it is from the time someone's admitted to discharge. This is where the process begins. This collaboration, you're not alone in the case. And some units, there is much more of, you could say, a triaging and expertise coming very early. Other units, you may be following, surgical protocols, and you're working specifically with a surgeon and maybe some medical oversight, but it's very specific. So it depends on where you are, but we always have to know that there's opportunities that we have to facilitate. So how does this happen? Well, we have to understand that it's incorporating our values, knowing our nursing roles, communication, which you've just had a module on. How does this fit in all together? I encourage you to think about creating something of your own philosophy. What is your nursing philosophy? How does it fit in with the national standards for nursing, right? So when we say what is nursing ethics, it is unique. We have unique ethics that we have to look at through the NLN, National League for Nursing, or especially as a North American, we share many of the same attributes with Canadian nursing, or through the World Health Organization. So it's very big. But then we have our own personal ethics that will pretty much match where your specialty is and where you're going to go. Look into that. Look into developing something like that. It's a process too. It evolves. It's not something that you have from day one. But that really will help you stay strong in what you do, because it is linked to burnout when we cross our own ethical boundaries and we don't have a clear boundary of what that is even. So it's very important. Legal can guide us a lot. We do have to stay within our roles, right, as they're defined, but our personal ethics and values are also brought to the table, and it helps us be more effective. We don't want to just have a legal process guiding our practice, but our own personal ethics as well. So that's why even with patient education, where does this fit in? this is where you want to look to see, well, we're trying to improve outcomes and behaviors, so there's a psychological component to this, and it is very vast. So as we're looking to say, we're creating a discharge plan, we're trying to maybe prevent a hospitalization from reoccurring. They used to refer to it as revolving door behavior. And today there's some stiff penalties. The government is not going to reimburse for hospitalizations that occur like even 30 days later from a recent hospitalization. They're really trying to crack down because they don't want things being missed. So that means there's a little bit more latitude for keeping people in the hospital a little longer. And that's wise, because there's too many things that can be missed if we, always see everything as a rapid turnover. It's unrealistic to think we're going to be thorough. Makes sense, right? So when we're talking about preventive and all of this area, boy, it's very time consuming. So that's why we are very focused on what people are their priority needs, what brought them to the hospital, and we try to let it stem from there. But we do want to be holistic, so there's opportunity to do more than just topical types of discussion, right? So the domains of learning, if you're putting on your educator hat, you're saying, okay, how can I reach this person intellectually? How can I emotionally meet where they're at and not be insensitive to that, or not being oversensitized to that either? We have to keep it in balance. Psychomotor learning, if it's something that is a skill, think of how many times we have to bring you back to the lab and say, come on, practice. And it's not about making it perfect. It's giving you that muscle memory, so that sometimes you'll do something and go, how did I just do that? Wait, let me break that down. I'm teaching someone who's never done something, whether it's cooking, cracking open an egg. Think about how delicate cracking open an egg is, to a child the first time they learn that. So, we're also having to take that into consideration and knowing it's not a one-time shot. How can we be effective? So in your books, there are, in chapter 12, 3 tables that you're going to need to look at. And I want you to understand how, how do we filter this through an older population member? How do we see, what barriers there might be to learning, right? So the care of the older adult, look through that table and see how you can take that into consideration. In 12.9, patient teaching strategies for patients with limitations or health literacy, right, issues, we have to understand, well, what is that? What do we need to be aware of with health literacy, and how is that defined? That's important for you to look at. And the last is 12.11, that is focusing on a methodology, which is a teach-back method, and it's a good one because it's the fastest way to really determine whether someone is understanding what they need to understand. And it's not about perfection. It's about saying, okay, that's adequate, or, well, let's try that again. You've got most of the idea correct, but let me fine-tune that for you. So there's a lot of psychological component here. We have to be careful not to just steamroll through our checklist thinking, well, I did what I was supposed to do. Yeah, but the person may have extra needs at that time that you have to take into consideration. All right, so just be aware. It's very important to take on the role of patient educator as nurses. If you don't enjoy this is going to be a major deficit in the type of practice you have. Being a patient educator is critical. People in the community call upon you to be a patient educator. So we all have to really hone this craft and work at it all the time. And we find ways to be effective even when you might not enjoy it as a first thing. You may want a specialty that's kind of behind the scenes in nursing, but you'll be surprised how people will still tap into your knowledge base and want to know things. So we can't get away from it. It's what we do. So we have to also understand Bill of Rights. So this is a little bit of a review. People have the right to refuse. You can try to teach somebody to give insulin, and they refuse. They will not touch that needle. Maybe they have extreme fear, and we cannot force that. But we have to find a way to transfer that skill, and that's a term for teaching someone something how to do, and now make it safe. And that's where we try to find a way to do that. All right, so remember that you're looking to it's promoting health and preventive health combined here. We're trying to restore that person's health and at the same time prevent readmissions. So that's why there's two components that have to be addressed. We don't want to just consider it just information only type of approach. Teaching and learning, they can be, there's one aspect that people can be very focused on what they're saying, but they're not taking in the evaluative process of learning. That's why we have to give assessments. As educators, we have to give tests. That's another word for assessment, is a test. And we know that it can be anxiety provoking, and that's why even as you're taking time to sit with somebody, are you sitting with them to talk to them about something that's very intimidating to them? All these feelings that you feel as a student are what makes you also very effective at the bedside when we do have to say, hey, let's take this off the staff nurse and educate someone on a particular topic. They many times don't feel as threatened coming from you or judged, so you'd be surprised how effective you can be, and also sensitive to see how this person is taking in the information. So our role is very important. Again, there's an ethical piece here. We don't want to leave somebody with a deficit that we know they're going to be right back here, but we're also looking to be fair to ourselves to say, is this person at a place where they are able to comprehend or even ready to make behavioral changes? It's a give and take relationship, and it's important because it's all about trying to not have somebody walk away with false information, right? And it can be very positive, and people really will appreciate and consider it life-changing that you were there at the center of maybe a serious health crisis for them. All right, so the cognitive, affective, psychomotor, that's, again, the learning domains. Remember that. That's pretty much a classic in education process, but you'll see it's missed often. The other is knowing that the motivation to learn. So I did put a little video on motivational interviewing, which MI, it's referred to, and it's a part of psychology. Counselors have to learn this, knowing that there's readiness to change and behavioral changes. It's not something automatic. It happens in phases, and that's why we do want to be aware of that. Okay, there's a very strong psychological component to that. And motivation, as I say, is defined as an internal state that helps arouse, direct, and sustain human behavior. But it's not exactly a flat line. It's up and down, up and down, up and down. So we're looking for trends. We're looking for things that are, hey, they're trending in the right direction versus, trending in the wrong direction. Say quite simply. All right. So, but there's also ability, right? Developmental capability. Age, we used to refer to as age-appropriate education. We want to make sure that we're not having concepts that are too sophisticated. Just because somebody can say a word doesn't mean they really comprehend that word. Also for understanding that the environment, oh boy, nothing like a construction site outside the window while you're trying to teach somebody something, or the phone constantly ringing, or the TV blaring in the background, or just too many people, too much interruption. So that's why it has to be planned. It can't be done, okay, let's just get this done off my checklist. It's not going to be done well if you don't take into consideration the environment. It's going to sabotage whatever you're trying to do. Okay, so that's why acute care is in itself a challenging place if someone can walk away with 20% of what you'd like them to understand, you're doing probably pretty good. The other 80% they're going to learn outside of the hospital, and that's why they need follow-up. Either the primary care, have a really good primary care help, or community health, nursing, connection, counseling, something to help them with that. Community support groups are also very good. So, just know that we have to make sure that we are being sensitive, taking in all of this. So we've added a component, right? Ability to learn, patient expectations, motivation to learn, teaching environment. It's quite a bit to gather. And then also, where's the collaborative process with that? Okay. So sometimes in our assessment, when we're seeing where someone's at, that is how we can also keep in mind when it comes time to have a case conference or talk about where somebody is. These are the very topics that do come up. All right, what's listed here. All right. Hospitals are getting very sensitive too about learning styles. Does somebody just want to have something explained to them? Are they someone who needs to be tactile learners? Children are often tactile learners. You have to make it something they can touch and feel, or somebody who might want to listen to something, quietly put on a headphone. Today we have that capacity with iPhones, just to plug in some earbuds and there you go. You got a little teaching going on there for the auditory learner. And also resources, do we have family? Do we have friends that might have this same problem, or being willing to come along and say, listen, I'm their support. I'm going to be here to remind them of the important topics and points that were made while they were in the hospital. Also teaching tools, like there may be kits. There may be something a manufacturer might make. I'm thinking of colostomy starter kits, somebody who might be a first-time person having a colostomy. You're not alone in creating these packets for them. Many times the hospital has them, or has a resource person that can get them. Okay, so just know that there are many aspects. Language is critical. If we don't have a translator or the proper person, and we need professional translation many times, we don't want to just rely on family for that, because, again, we could have something lost in translation. Okay, so health literacy, that's very important. It is defined by the Institute of Medicine as an individual's ability to obtain, process, and understand basic health information and services to make appropriate and informed health decisions. Wow. That's really important that we say, do they have access? You hear that word oftentimes. Access is a big health literacy issue. Access to care. Is the information that's available to them written at a level, and they usually say 6th grade writing level. So keep it simple. Why? Because people are anxious, and you have to use simple language. We don't want to get into medical speak when someone is learning something for the first time. And we can all do it. We can all slip into that jargon because, well, it makes us look competent, right? But that's not to their best interest, so we have to dial it down a little bit and then bring it back up. I'd like to let them know, I understand, and I'll help you with this word. People will impress you too with their ability and maybe their background too. So you have to treat everybody the same there. Just because someone has a medical training in their background, don't think their health literacy is 100%. They might be much higher than the average person, but when you're vulnerable and you have an illness, it's going to impact your ability to absorb things. Okay, the hippocampus does not function at its best. That's the part of your brain for retaining knowledge, right? If you're anxious. Okay, so that's why some anxiety is good, keeps us alert. Pay attention when we fall asleep in the middle of a lesson. But once you get to that moderate and high levels of anxiety, now it's blocking. Now it's blocking. And you have to look for signs of that in a person. To say, hey, you want to take a break? Let's get back to this, after maybe 20 minutes. Well, let me let you have, and also some food, let them eat before you start to have them use some brain work to learn things, right? That's why we have to give you bio breaks and while you're in school, and opportunity to eat something and Intake and elimination, very important. Special needs, we have to take that into consideration. Some are very capable, so we don't want to think they're not, just keep them out of the center of it. But we also have to be aware of, the learning curve. Middle age, sometimes we have opportunities, people are motivated, they want to make it to the older years, however, they have a lot of distractions. So it's not that they're resistant to behavioral changes, it's just that there's many things interrupting their effort to make those changes. And there's long-standing behavioral patterns too that are hard to break. Okay? Older adults, now we may have sensory issues, we may have visual, hearing, and again, cognitive, slowing down. That doesn't mean they're not able to learn, it just means grasping the concepts just because they've had long-held beliefs on certain things. You have to be patient and slow down. Talk to them in a way that lets them know you're taking time. You're not rushing through, and that's tough because there you have the generational gap right there where people are speaking in a million words a minute and they're not absorbing that. So you have to really slow it down. Okay, make your words very clear, distinct, and check back. Does this make sense? What I'm saying? Things like that, getting feedback along the way. So nursing diagnosis is this little green, look for, sometimes I try to get a slide that's got some green, meaning like, this is a good go-to for you, because when you're creating plans with your clients, education is a wonderful thing to incorporate in your weekly clinical assignment. And these are some really nice ones to pull from, all right? So when we say knowledge deficits, which area? Again, affective, cognitive, psychomotor, sometimes people can feel depressed, and maybe that's why that's hindering their ability to learn something. And you have to deal with that depression. You can't just overlook it and be like, oh, you'll be fine, don't feel sad. That's not going to work. Okay, non-compliance with medical schedule. That word non-compliance, it's on here. I may change it. Non-adherence. We don't want to use the word compliance anymore, because comply kind of indicates you're not sticking to my plan. But adherence is kind of saying, it's that word again, sticking, adhere to something. But you might say, well, all right, tell me what will stick with you. What can you stick to? Versus, obey. I think that's what I was trying to say. So compliance is more of obedience, where adherence is more of a, hey, well, tell me what sticks with you. What do you think you can work on? That kind of thing. So it's a little bit less dogmatic approach. All right, so look through those. That'll help you. Also in the nursing process, just remember we use a process. That's part of nursing, right? In our planning. So, and here you're looking to see from the very beginning, what are you trying to achieve? So that's why, assessment, nursing diagnosis, outcome. We're thinking of our expected outcomes kind of early at OPI, if you've heard that one, but it helps you with the planning process, because you don't want to make a plan for something you can't achieve. Remember that when you're doing nursing care plans, sometimes they're very lofty. We might make some amazing care plans, but that person is not going to be able to achieve that. So always make a plan that's achievable, and then you build on success, and that's motivational for people. That's part of motivational theory too, is prior success, where they've been successful, and building on that. All right, so look through here, but as you look through this too, use collaborative care. See, that is part of the planning process. So here we were, doing all those things about making a productive teaching, but we also want to make sure that we're utilizing good resources, because they reinforce and support what you're saying. It actually builds a good unified front, but it's also a shared burden. I like to say that, like if we have a complex case, you want to bring in, extra reinforcements, so that, team conferencing and not overwhelming the client, but making sure that they know that we're all talking to each other and trying to bring the best solution here. Okay, so there are different ways to do this, how we approach it, and depending on the setting you're in, might lend to why some things are done a little differently. We can't always fit, one size does not fit in all areas, okay? Keep that in mind. And again, the teach back, which I do refer to that in that table that I want you to look at in chapter 12, the teach back method, that's very good for one-on-one discussions, all right? Group instruction, sometimes they don't have those as available in the hospital, but sometimes they do, like if you're in the maternity area. La Leche, I think, has a little bit of a group. Sometimes new moms, they might have new mother classes or labor, preparation classes, things like that are done in group. But we have to look for the group ones in the community, and that's where it does take other people to come in to let you know what's available. So that's why staff educators in a hospital are helpful, as well as social workers, to find out what might be in the community, because you have like workshops that are offered in the hospital, and then there's workshops offered in the community. So all of these things, preparatory instruction, you might say, well, what could I bring into the room, to give someone, or put on television, something that the hospital offers, say pre-op or post-op teaching, demonstrations. Again, usually those are for more psychomotor types of things, or, helping people see a special way to use an inhaler or injection. So all of these things have use, and they're helpful. Keep that in mind. And we want to make sure too that we have someone's undivided attention. You don't want to be teaching someone who's groggy. That's why it is good to find ways to get some feedback, whether you give somebody a checklist. Would you prefer I give you a little checklist of things that we're going to talk about, and we'll check them off as we talk about them, or give you a handout of some sort, and can you read a certain section aloud with me, and we'll take turns going over it. Tell me what you're familiar with, what you need more education about, things like that. Where would you like to begin? Those are all ways to elicit some participation. You have to ask some questions, but non-threatening. You don't want to be, well, why I have to talk to you about this. that would not be respectful. And nurses can slip into that. Doctors can too. People that it would surprise you. So we have to be careful. We have to really have very good self-awareness, center ourselves before we go ahead and do this. Okay? And also, somebody might not tell you that they have certain disabilities. They might have difficulty reading or comprehension of some sort. So that's where we have to be sensitive to that as well. And that can be a little tougher to detect, right? So looking at, that's why we usually ask upon admission, what level of schooling has somebody completed. Hopefully they're being truthful. And cultural awareness too, because there's some topics that might make somebody very uncomfortable to talk about, or the taboo topics. So it's really important to know about that. All right. So here, as we wind down on here, just know that documentation always is important. We're looking to incorporate, what approaches we used. It should line up with the nursing diagnosis, and we don't want to overly grade it positively. If we think follow-up is necessary, we should say that. That's important. Okay. Also looking at the family, when we bring in family for support to a client, we want to make sure that family dynamic is a good one, right? Because that family can be the make or break for a safe or unsafe discharge. This is all about discharge planning and making it a safe thing. So look through the rest of this, how we define family. Family is, we refer to it as a significant other. Sometimes that's a person's family. It might not always be a legal bond, but that's, or a biological one, right? But we still have to be aware that that's that person's support person. So we may want to incorporate them. And that's why, or if you have a family member in the room, you don't want to assume, oh, let's talk about this topic. A great one is to say, the people that are in this room right now, are you comfortable with us with education, or would you rather finish up your company and I'll come back, how would you like this? You have to think. You have to just stop and think. Don't just introduce topics of conversation with who's in the room because you're not sure, right? You have to assess that. Okay, is it okay to talk about this now, or would you like to talk about this later after your company leaves? You get the idea. Okay. Also, we're looking to see, what on admission, we want to know the support system. We want to know the risk factors if somebody lives alone. Sometimes they live in a very supportive advanced age community. I call it advanced age, senior community. We don't want to just assume that they have no support. They may live where the neighbors check on each other all the time, and that's great. So that living alone is not so bad as someone who might be living alone in a house on a 2-acre property, and you're like, okay, they're kind of isolated. So we just want to know that there are health disparities that financial can create it too, homelessness, somebody who's in a destructive relationship issue. This is where family can also hurt a person's ability to have a good, healthy behavioral lifestyle. They just don't have the supports. Okay. Structure and function. We also want to take into account the age spans in a particular family, and what is their philosophy. Every family does kind of have a philosophy of health. Eat, drink, and be merry. That could be some people's philosophy. Other people, it's very strict, and they don't. They live within very clear health boundaries. Yeah, and that could just run the gamut. You never know until you explore that. Okay, so we just know that there is a great knowledge base that we have to consider when we're looking at family, and just know that they have a big influence on the outcome. All right, so having a bridge to that is very helpful. Not to look at that as just as bad as the environment that I was saying. You can't teach in a hostile environment. Same thing. Family can bring really wonderful experiences or some big challenges. So we do have to be careful of that. And sometimes a family won't accept what's happening to a person, or they blame them for that. And so, we do have to safeguard our client first. We're there for the client. Remember that. Okay, and also there's acute care issues. Somebody that's expected to rebound. How the dynamic of the family. They really rally around that person. But then if it's a chronic illness, you may have a lot of burnout. You may have caregiver burnout that's happening. Trauma. The family may be buckling at the knees with what's going on around, and you have to be careful. Make sure there's a couple of chairs in the room. There's all kinds of dynamics that go on. End of life has its own, way we have to bridge to family and be compassionate. So these are challenging areas. The family does add to our roles, and that's why today when we're advocating for nurse-patient ratio, it's really because of all of these things that are being involved. Years ago, and not for me though, because I always had units that I worked where families sometimes had unlimited access. They could come in anytime, day or night. And I liked working with family, but sometimes, going back probably 10 years before I started in the 70s and 60s, you had visiting hours. They were very strict, So nurses weren't accustomed to working with family as much. It was kind of, the doctor and the patient. And so it's changed a lot. Okay, so there's many aspects that we're filtering through, and as I've already discussed a lot of these, and we're looking to make sure that it's a healthy situation, a healthy dynamic that's happening. Okay, and when it is a healthy one, we can incorporate families into the outcomes, and working, with the other interdisciplines, collaboratively. And, really make it a sit down. And you see this with pediatrics quite a bit. Peds really works with the family at the center. So keep that in mind depending on what specialty you want to go in, right? Health promotion, acute care, restorative continuing care. We have to try to put it in the proper perspective. So when we're talking to someone, if it's even a pre-op situation versus post-surgical, communications in acute care is very important, that we're very concise and clear as to what we're trying to deal with and educate about. Health promotion, we're just preventing reoccurrence as much as possible, right? And that's even in the cancer facility. That's what they're trying to do. They're trying to decrease reoccurrence of cancer, right? After they've maybe successfully treated. And restorative continuing, if someone goes to a skilled nursing or a rehab because of a trauma, it's going to be protracted. You're going to need 6 months, maybe longer, before that person is at a place where they can even go home. They may never be what they were before the trauma, but they have their new normal type of thing. Okay, so this is pretty much the wrap up. We always evaluate, and part of the family dynamic is also part of the evaluation. And we don't want to be adversarial. We don't want to come across as if we're the judge and jury, but we definitely want to look to get social workers involved if there is a problem. Okay, that's pretty much the handoff. So if there's a problem, don't be alone, right? You want to get some expertise around that. If it's really smooth and wonderful, then you could work with it almost on your own. But today we have a lot of discharge planning committees and coordination of care. So when you have that, you want to use it. You don't want to be alone if you can have other people help out. But as experience builds, there are some things that you can handle very expertly on your own, and it's smooth. Okay, so that's it for now, and we will do some things in class to reinforce these concepts, and I thank you and have a wonderful rest of your week.